Hi, and welcome to another edition of Your Health with Dr. Christy. My name is Dr. Christy Reisinger, and today I'd like to give everyone a piece of my mind about ivermectin, medical misinformation, and censorship. I'd like to first start off by saying that if you've watched any of my videos, you know that I believe the vaccines to be safe and effective, and they're the best way to prevent serious illness, death, and hospitalizations. This will always be my top preventative strategy to fight COVID-19. Next, if you're a patient of mine and contract COVID-19 and meet certain high-risk criteria, such as an age greater than 65, or if you have other health conditions that increase your risk, such as being overweight or obese, have chronic kidney disease, diabetes, or chronic lung disease, I'm going to recommend that you get a monoclonal antibody infusion at a local infusion center or hospital if and when it's available. However, there is a subset of patients who have contracted COVID-19 who I feel should be given the consideration for treatment with ivermectin. Let me explain my reasoning and the latest data behind this. As much as the medical community would like to have everyone over the age of 12 vaccinated, as we've seen in the United States, there's always going to be a subset of the population that's simply not going to do this, either because they're concerned about the side effects or have had a reaction to vaccines in the past that may prevent them from considering the COVID-19 vaccines. Furthermore, as we have seen with the Delta variant, there are some patients that, despite being vaccinated, still contract COVID-19 and can have pretty miserable symptoms ranging from high fevers to loss of taste and smell, and even some hospitalizations. Furthermore, there are patients that either do not have access to the monoclonal antibody infusions because of transportation issues, or because the infusion centers are backlogged for several days because of high demand. And as we know, the earlier treatment is started in COVID-19, the better. And this is the subset of patients that I think should be considered for treatment with oral ivermectin, prescribed by a physician and obtained from a reputable pharmacy for up to 5 days or until symptoms resolve, whichever comes first. Is the data on ivermectin clear-cut? Absolutely not. But there are trends in the direction that when used early in the course of a COVID-19 illness, ivermectin can possibly prevent worsening of symptoms, clear viral load, and prevent hospitalization. And yes, I believe there is enough data to show a positive trend for this medication when we're in a pandemic that's killing people. Currently, ivermectin has this statement attached to it from the NIH that states, quote, "There's insufficient evidence for the panel to recommend either for or against the use of ivermectin for the treatment of COVID-19. Also, the WHO does not recommend against the use of ivermectin, but simply states that the data is inconclusive and that it should only be used in clinical trials. The FDA has not approved the use of ivermectin for the treatment of COVID-19, but I guess I would say that until recently, none of the COVID vaccines were formally approved by the FDA either. And we've used those anyway, and they have proven to be a huge benefit. Furthermore, did you know that 10 to 20% of all prescriptions in the United States are prescribed off-label, meaning that they are being prescribed for conditions that have not received FDA approval? There continues to be enough interest in ivermectin to prompt a large clinical trial by the University of Oxford called Principle to study the use of ivermectin for 3 days early in the course of a COVID-19 illness to see if it prevents progression and worsening of COVID-19. And the NIH has expressed enough interest in ivermectin as an outpatient treatment in COVID-19 to include it in a trial called ACTIV-6 that's currently underway. The most recent study on ivermectin is a meta-analysis that is not peer-reviewed or published, but it looks at 63 studies from around the world. Of these studies, 44 of them are peer-reviewed and 31 are randomized controlled trials. Doses of ivermectin ranged from 12 milligrams a day up to 84 milligrams a day and were used for an average of 4 days. Endpoints in the studies range from clearance of viral load to reduction in hospitalization to reduction in death. And as you can see from this graph, overall, there were improvements in these areas. And overall, the trend with using ivermectin is positive. If you would like to continue to see the latest data on ivermectin, please go to c19ivermectin.com. But I will agree that many of these studies are poorly done and have a lot of bias, and more controlled studies need to be done. There have been recent warnings from the CDC against using ivermectin obtained from veterinary sources, meaning people are obtaining and ingesting ivermectin without the oversight of a physician in forms that are meant for horses and cattle. I will never advocate the use of ivermectin this way. But why can't we consider pharmaceutical-grade ivermectin prescribed by a physician and given at doses that have been shown to be safe for patients that either refuse the vaccine, have a breakthrough infection despite the vaccine, or do not qualify or are unable to get monoclonal antibody infusions? I just don't see that the risks of using ivermectin at doses known to be safe outweigh the benefits of using this medication in this subset of patients with COVID-19. At this point, the treatment recommendation that we currently have to give these patients is get a pulse oximeter, take some Tylenol for fever, rest, and hope for the best. Go to the ER if your symptoms become so severe that you cannot manage them at home. And by then, we have missed a precious window of opportunity for treatment. But then this leads me to a recent example of another issue that physicians are running into. Pharmacists that are refusing to fill prescriptions for ivermectin, which I do not think is right. I recently had a patient in his late 40s that contracted COVID-19. He had a prior infection with COVID-19 and declined to get vaccinated despite my recommendation for him to do so. He's not overweight, nor does he have any other medical conditions that allow him to qualify for a monoclonal antibody infusion. He and I both agreed that ivermectin was a reasonable approach to treating his COVID-19 early on, with the hopes that it would prevent progression of his illness. I called in a dose of ivermectin for 5 days based on the protocol referenced online by going to FLCCC.net. I called it into the local Walgreens pharmacy in my town. Shortly afterwards, I received a call from the pharmacist telling me that he was not going to fill the prescription. Despite clarifying the dosing with him and my reasoning for prescribing the medication, he simply said, "I'm not going to do it." Needless to say, I was frustrated, outraged, and powerless. I eventually did call the medication into a compounding pharmacy that was willing to fill the prescription as I had written it. As a general internist, I believe myself to be a rational person. I do not see using this medication for this subset of patients as risky to patients, and on the contrary, it has a possibility of providing benefit. This medication does not require an infusion center, it can be easily obtained when a pharmacy agrees to fill it, and is inexpensive. And as we know from our study of COVID-19, the earlier outpatient treatments like monoclonal antibody and ivermectin are started, the better the outcomes will be. In a perfect world, we would have double-blind, placebo-controlled studies on ivermectin showing its benefits in the treatment of COVID-19. Instead, we're left with 63 studies performed around the world that, while flawed, do show a beneficial trend toward the direction of a benefit to using ivermectin early in the outpatient setting. Isn't that enough for these patients that either refuse to get the conventional treatments we recommend or don't qualify for them? And I want to end this segment by saying I will never recommend ivermectin in place of the COVID-19 vaccine or even monoclonal antibodies, and that any medication should be prescribed by a physician. I want to continue to thank the Frontline COVID-19 Critical Care Alliance, better known as the FLCCC, for their tireless work and efforts to treat COVID-19. Thanks for joining me.